Please look here. Cholesterol LDX system. Cholesterol LDX system. This is a bedside instrument. Just like you look at blood glucose using a glucose monitor, using this instrument, we can get the values of the entire lipid profile, blood glucose, the enzymes of the liver SGPT and SGOT and HCRP in a matter of 5 minutes using a finger prick blood. Isn't it amazing and surprising? This particular gadget is available as a cartridge, and each patient will be supplied, each patient we have to use one cartridge, and this cartridge, once it is exposed to the finger prick blood and is put it in the counter gives the reading, and this test is going to come in India very soon, and it should be very economical too to do all these tests at the bedside. We already have such a bedside test, such a clinical applicability test for HbA1c apart from glucose monitors, and this is this Cholesterol LDX will be a wonderful gadget for all of us to have in our clinics to look at all these values in such a short time. The accuracy of this surprisingly is amazingly high, and it correlates with the lab values to the tune of around 95 to 98%. So that is the correlation coefficient of this particular test. I am presenting here a diagnostic algorithm for fatty liver. If we find a patient with the risk factors for fatty liver like obesity, hypertriglyceridemia, insulin resistance, diabetes mellitus, age more than 45, or history of taking any medicines which can cause fatty liver, or if he has got features of metabolic syndrome, then an imaging of the liver using ultrasound is mandatory. If the imaging shows fatty changes in the liver, so the ultrasound is positive for fatty changes, then we need to measure the serum enzymes, liver enzymes, SGOT and SGPT, and also ask about the alcohol use by the patient. If the patient says he takes 2 or more drinks per day, then that is excess alcohol, and we are dealing with alcoholic fatty liver. Supposing the patient says that he is non-alcoholic or drinks very few times in a week, and there is a limited alcohol or no alcohol, then it is non-alcoholic fatty liver disease. Again, when the liver enzymes are elevated, if the transaminases, when we estimate the transaminases show a high elevation, we have to rule out other diseases which cause increased transaminases like hepatitis C, hepatitis B, autoimmune hepatitis. Then again, imaging of the liver will help us to identify the fatty changes and go with the flow chart. So if the other diseases like hepatitis C or hepatitis B or the autoimmune hepatitis tests are negative, then we are dealing with NAFLD. If they are positive, a specific diagnosis of that condition is made and treatment plan is according to the diagnosis. This algorithm is reproduced from the American Gastroenterology Association guidelines. So the diagnosis of fatty liver, ultrasound is enough. CT is required only if the USG is not informative or confirmatory. Imaging can detect more than 30% or 33% of fat on liver biopsy. Cannot differentiate. The drawback of this ultrasound, it cannot say whether it is NAFLD or NASH or fatty liver from fibrosis, steatosis from steatohepatitis. So for that to be quantified, we either have to use the Mayo score or the Hare score or the BAT score, or go for liver biopsy. But usually liver biopsy is not needed to diagnose fatty liver. As we have already discussed, when we find out that the liver enzymes are elevated, we need to exclude other common disorders like hepatitis B virus disease by doing a HBS antigen or HBV DNA test. Then also, of course, hepatitis C, which is often associated with elevated transaminases, by anti-hepatitis C virus antibody, or doing a direct hepatitis C virus RNA estimation using PCR. Autoimmune hepatitis needs to be excluded by doing an antinuclear antibody test. Alpha 1 antitrypsin deficiency by estimating ATT. Wilson's disease by looking at ceruloplasmin levels, which will be decreased in copper storage disease, Wilson's disease. Hepatic malignancy, of course, requires several other tests apart from CT and also a liver biopsy. Maybe you do a CEA, carcinoembryonic antigen. Hepatic infections and biliary disease, of course, need to be excluded when there are elevated transaminases. In the clinical features, we are talking about Acanthosis nigricans. Look at these pictures here. The one on the left hand side is deep black pigmentation of the axillary region, very common presentation of Acanthosis nigricans. The picture on the right hand side, you see the neck of the patient studded with black pigmentation all around. So these are quite common in people who have visceral obesity, who have insulin resistance, who have metabolic syndrome, and this Acanthosis nigricans is a marker of the underlying insulin resistance syndrome, and of course insulin resistance syndrome is associated with fatty liver and NASH. We will see some more pictures in the next slide. Here are some more pictures of Acanthosis nigricans, black pigmentation of the axilla, and look at the knuckles here in this patient. This diagram, this particular picture, the knuckles are deeply pigmented compared to the fingers, and this is a very characteristic feature of Acanthosis nigricans. Remember, all Acanthosis nigricans is not insulin resistance syndrome. Acanthosis nigricans may be due to several causes, but if you have Acanthosis nigricans, we can surmise and look for metabolic syndrome and features of non-alcoholic fatty liver disease or NASH.